Good morning. I'm Dr. ASWATHI. Today we are going to discuss about management of open bite. Uh, According to Garavili, open bite can be described as occlusal characteristics in which upper and lower teeth are not in contact and the vertical overlap does not exist. Now, normally in occlusion there is a vertical overlap of 2 to 3 millimeter, and in open bite this overlap is not there. So this open bite can occur in the anterior region or posterior region. When it occurs in the anterior region, it's known as anterior open bite, and in posterior region, it is known as posterior open bite. And the diagnosis, treatment, and successful prevention of treated open bite malocclusion continue to be a challenge to the clinician, which is considered as the most difficult case to treat and to retain. So it's considered as a challenge to the clinician. Coming to the classification of open bite, based on the location and based on dental or skeletal component, open bite can be classified. So, based on the location, as we described earlier, open bite can be anterior open bite or posterior open bite. And based on the dental and skeletal components, the open bite can be classified as dental open bite and skeletal open bite. An anterior skeletal open bite can also be known as apertognathia. It is a different term, apertognathia, which is known as anterior skeletal open bite. And the next classification is given by Worms, Miskin and Isaacson, and its classification is based upon the complexity. Open bite can be classified as simple open bite, complex or compound, which is also known as infantile open bite. In simple open bite occurs from the canine to canine region. It's about 4 millimeter or more. In complex open bite, premolar to premolar uh, comes in the open bite, and in compound or infantile open bite occurs from the molar region to molar region, which literally there is no bite between the upper and lower teeth, because molar to molar are in open bite. And commonly the complex open bite and compound open bite got some skeletal component in that, and it is very difficult to treat complex and compound open bite. And it's also known as infantile open bite because it is due to a retained habit, or infantile open bite is due to a habit. Classification of open bite according to Moyers, which is again as simple open bite and complex open bite. And in simple open bite, there is failure of teeth to meet the line of occlusion. And in complex open bite, which is caused primarily by the vertical dysplasia. In anterior open bite, there is no vertical overlap between the upper and lower anteriors, and it is aesthetically very unattractive. And anterior open bite can be either dental or skeletal. When it comes as dental, it's easier to treat, but the skeletal open bite, which is also known as apertognathia, is very difficult to treat. The etiology of open bite. Actually, we can't pinpoint an etiology to the open bite. It's considered as a multifactorial, and hereditary and non-hereditary, means environmental factor also play a role in developing open bite. The one of the main culprit which lead to the anterior open bite is habit, and many number of habits are there, among which the thumb sucking, tongue thrusting becomes the most common culprit in developing anterior open bite. And in mouth breathing, nasopharyngeal airway obstruction also, anterior open bite can develop, and it can also happen as an inherited factor due to increased tongue size. In individuals with increased tongue size, there is thrusting of the tongue anteriorly leading to the anterior open bite. In abnormal skeletal growth patterns, means the growth pattern can be due to the rotation of maxilla or mandible, in which normal clockwise rotation or counterclock rotation happens. When the clockwise rotation happens, it results in the open bite, and in the clockwise rotation of mandible, that is downward rotation of the mandible, also can result in open bite. In case of vertical maxillary excess, Also open bite can occur, but it is not that common. An iatrogenic open bite, which is as a developing as a any intervention, or which is developing as a part of any other treatment modality, it can develop. And pathological open bite, muscular dystrophy, these are the certain factors which can lead to the open bite. Then coming to the features of skeletal anterior open bite. So first we have to assess the extraoral features. Usually the patients appear have a with anterior open bite may have a typical appearance in extraoral examination. Usually presented with long and narrow face, short upper lip with excessive maxillary incisor exposure, increased anterior facial height and decreased posterior facial height, that is there is alteration in the Jeraback ratio. Also there may be increased lower anterior facial height and decreased upper anterior facial height, that is alteration in the vertical thirds of the face. Decreased nasolabial angle can be considered as one of the feature of anterior open bite. And also patient may be presented with shallow mentolabial sulcus. Then moving on to the intraoral features, usually uh, open bite is associated with a narrow maxillary arch, especially those patients who are having some kinds of habits. And the open bite may be presenting as an anterior open bite or posterior open bite. Excessive gingival display and decreased freeway space can be considered as a feature of open bite. In cephalometric features, usually presented with small mandibular body and ramus, divergent cephalometric planes, steep cranial anterior cranial base, and steep mandibular plane angle. And as discussed earlier, there may be clockwise rotation of mandible and or anti-clockwise rotation of maxilla. When it occur in the maxilla, it's anti-clockwise. In mandible, it is clockwise. When there is this clockwise and anti-clockwise rotation of maxilla and mandible is there, there is increase in severity of the anterior open bite. Then coming to the features of dental anterior open bite. So this open bite is due to a dental cause. They do not present with a skeletal complication, which is easier to manage. It's associated with proclined upper and lower anterior teeth, spacing in the maxillary and mandibular anterior segment, and patient is usually presented with narrow maxillary arch due to lower tongue posture due to the habit, and patient may be presenting with a typical fish mouth appearance. Treatment, the first aim of a treatment is to remove the etiologic factor or remove the cause that is leading to the open bite using habit breaking appliance, either removable or fixed, like fixed grip appliances can intercept the habit which is leading to the open bite, and the persistence of cause will be a limitation in corrective procedure. So if we are able to intercept properly in a habit to prevent the development of open bite, it is having a better prognosis than the cases having presence of the cause. Then coming to the myofunctional therapy, like Frankel 4 or a modified activator, that is incorporating bite blocks interposed between the posterior, which is having intrusive action on the posterior, helps in the closure of open bite. The bite opening beyond 3 to 4 millimeter, that is beyond the rest position, inhibits the increase in height of buccal tendoalveolar process, preventing the downward and backward rotation of the mandible. Then vertical put headgear with a chin cup, the patient with downward and backward rotation of the mandible with increased vertical growth. This vertical pull headgear can be used with the chin cup. Chin block appliance with a high pull headgear. Anterior open bite with last skeletal pattern. We can give it in block appearance. So it helps in the correction of skeletal class 2 pattern along with the anterior open bite. Correct anteroposterior discrepancy while controlling the vertical dimension. That is anterior class 2 skeletal pattern is getting corrected along with the correction of anterior open bite when we are using a twin block appliance with a high pull headgear. Then coming to the orthodontic therapy, so when the open bite is mild to moderate, okay, we can treat it with the fixed orthodontic appliance. Ideally, we can do the intrusion of posterior teeth or extrusion of the anterior teeth. Extrusion of the upper and lower anteriors, that is considered as a dental compensation. We can use box elastic or extrusion arch wires. This box elastic, you can see that red elastics which is given in the shape of a box or rectangle helps in correction of anterior open bite, and also this extrusion arch wire helps in the correction of anterior open bite. And in the severe cases where this previously discussed mechanics does not work, we have to search for the surgical correction of open bite, which is usually done in the adult cases having very severe condition which can be managed. So in the adult cases, surgical procedure involving maxilla and mandible is to be done to correct the anterior open bite, usually Leaford 1 osteotomy in the maxilla. In case of posterior open bite, which is a condition characterized by the lack of contact between the posteriors when the teeth are in centric occlusion. So see, even if the teeth are in centric occlusion, if the posteriors are not contacting, we can consider it as a posterior open bite. Mostly occur in a segment of posterior teeth, and this posterior open bite can be either unilateral or bilateral. And etiology of the posterior open bite. The most common etiology is a lateral tongue thrusting habit. Mechanical interference with the eruption, that is ankylosis of the tooth to the alveolar bone, obstacles in the path of eruption such as supernumerary teeth, non-resorbic deciduous tooth roots, and also the pressure from the soft tissues interposed between the teeth. Okay, and next is failure of eruptive mechanism of the tooth so that expected amount of eruption does not occur. The treatment of the posterior open bite, the first option is the removal of the cause, and second option is interception, where the lateral tongue spike aid in controlling the lateral tongue thrusting, like the anterior spike, crib with spike, we can give a lateral tongue spike or crib to control the lateral tongue thrusting. And also the fixed appliance. Forced extrusion of the posteriors, that is ankylosed or submerged teeth, we can forced extrude and close the posterior open bite. In case of ankylosed teeth, it is best treated with a crown on posterior to restore the normal occlusion. As the teeth is ankylosed, we can't move it with an orthodontic force. So, giving a good crown to restore the normal occlusion is ideal in this case. So this is about the open bite. So we have covered the normal portions about the